Hi everyone, my name is Nicole Luongo and I'm here today representing the Canadian Drug Policy Coalition, or CDPC. CDPC is a policy advocacy organization comprised of multiple member organizations and individuals who are collectively striving to end the harms of drug prohibition. We operate as a project within Simon Fraser University's Faculty of Health Sciences. That being said, although we are based on the West Coast, we are national in scale. My role with the CDPC is Systems Change Analyst. What that means will depend on the day, but I do a combination of policy analysis, policy advocacy, and coalition building. A little bit about me personally. I was born and raised in what is colonially known as Vancouver, although since last year I've been based in Toronto. I personally identify as someone who has extensive experience of criminalized drug use and all that comes with it. I'm also disabled, which is relevant for the purposes of this presentation. Beyond that, I have an academic background in medical sociology, where my research critically interrogated how the mental health system can resemble policing institutions, particularly for disabled people. And I am a proud member of, some grassroots drug user and kind of harm reduction advocacy groups as well. Now, in terms of my presentation, the title will be Drug Prohibition Causes Disability Poverty, Why Disability Justice Must Include People Who Use Drugs. And I'll say that this presentation is going to be characterized by probably a lot of breadth and less depth than I would prefer. Just given the time constraints we have, I won't be able to delve into any specific topics too extensively. But of course I will be present in December for the symposium and very happy to elaborate on anything I say. So just to offer a bit of an outline in terms of what I intend to cover here, I'll start out by saying that Canada is in the midst of a severe, unrelenting public health emergency. Across the country, approximately 28 people die each day of unregulated drug poisoning, and countless others suffer acute and chronic injuries. While rates of drug use and substance use disorder diagnoses have not increased since 2016, overdose fatalities, hospitalizations, and injuries have skyrocketed. Now, it's unclear how many drug-related deaths and injuries occur among disabled people, as no level of government tracks this information. Nevertheless, it is broadly understood that disability is associated with illegal drug use, particularly for those who are poor. Consequently, poor disabled people who use drugs, or PWD, as we refer to people who use drugs, are at a significantly elevated risk of fatal overdose and disablement. What is more, because unregulated drug possession is criminalized, drug users are functionally exempted from the prohibitions on discrimination due to disability and socioeconomic status that are enshrined into domestic and international legal instruments. As such, the overarching theme of this presentation will be that Canada's drug policy regime does not just punish pre-existing disability, it actively produces it. That is, Canada's drug policies and laws are disabling unto themselves. So with this presentation, I have a few kind of high-level objectives. The first is to articulate the pathways through which drug laws and policies intersect with institutionalized disability poverty to cause death and disablement at scale, to offer examples of policy and legislative reforms that would stall or reverse this trend, and, time permitting, to propose a few concrete strategies, or at least encourage people to think about a few concrete strategies for meaningfully including the perspectives of poor, disabled people who use drugs into disability activism and advocacy. So as we begin, I want to just start with providing a few definitions to kind of set the stage for everything I'm about to say. The first of them would just be drug prohibition. In my world, it's kind of taken for granted that people know what I'm talking about, but I recognize that this term isn't clearly defined. So for our purposes, drug prohibition refers to the legal architecture that imposes criminal penalties for drug-related activities. And prohibition transcends borders. Canada is a signatory to the 1961 United Nations Single Convention on Narcotic Drugs, the 1971 Convention on Psychotropic Substances, and the 1988 Convention Against Illicit Trafficking, which together form the international drug control system. And again, I wish I had time to expand on that, but suffice it to say, drug prohibition has very much served the interests of Western nation states, in terms of kind of justifying interventionism and regime just destabilization, both historically and currently. Now, domestically, Canada's federal regime of prohibition is called the Controlled Drugs and Substances Act, or CDSA. The CDSA dictates how various substances can be imported, exported, manufactured, distributed, and possessed, as well as the criminal penalties associated with various drug-related offenses. It also shapes provincial and municipal level policies and laws. So provinces and municipalities must apply to Health Canada at the federal level for an exemption to the CDSA to implement any policy change that is out of step with it. This is further complicated by the fact that provinces are broadly responsible for healthcare decisions. So provinces do have the power to approach drug use as more of a health issue, but to date, none has really been willing to fully exercise this power. And just to illustrate how this works in practice, in Canada, safe consumption sites can only operate if they receive an exemption to the CDSA from Health Canada. Yet in 2016, the province of British Columbia declared a public health emergency due to rapidly rising rates of overdose. This afforded BC Emergency Health Services and regional health authorities the ability to provide overdose prevention sites, or OPSs, as necessary on an emergency basis. OPSs function quite similarly to safe consumption sites, or SCSs. Both of them provide kind of clean, safe places to consume drugs and are staffed with folks who will respond in the event of an overdose, but the two are legally distinct. OPSs can operate only in BC without having to apply for an exemption. However, SCSs still require an exemption. And when BC implemented a temporary decriminalization policy pilot in 2023, it still had to do so with permission from Health Canada. So there's a lot of legal, not ambiguity, just complexity embedded therein. But again, for today, all you need to know is that prohibition is that legal architecture that criminalizes most drug-related activities, with the exception of drug consumption, which might sound a bit odd, but possession is criminalized, and of course, in order to consume drugs, you must be in possession of them. So consumption is kind of de facto criminalized as well. Moving on, the term unregulated drug crisis is one I will use quite a bit. And I use that term for very specific reasons. Prohibition has created a toxic, unregulated drug supply. And I want to emphasize here that drugs are not prohibited simply because they are dangerous. They are much more dangerous than they need to be because they are prohibited. Unlike every other consumer good, including legal drugs such as alcohol, cannabis, caffeine, illegal drugs are not subjected to government regulations, hence the term unregulated. There is therefore no quality control embedded throughout the supply chain. And so people who manufacture drugs, which exist kind of in the criminal realm, add potent adulterants to the drug supply to reduce the costs associated with manufacturing, transport, and storage, and to reduce the likelihood of interdiction or seizures by law enforcement and border security agents. As a result, the contents of illegal drugs change rapidly and are entirely unknown to consumers. And it is this unpredictability that is the main cause of overdose, not drug use itself. And this is why I'm going to be using the term unregulated drug crisis or unregulated drug toxicity or death versus opioid crisis or addiction crisis. Virtually no accidental drug-related deaths are caused by prescription opioids anymore. And most deaths in Canada anyway occur among people who are not diagnosed with a substance use disorder or who don't identify as experiencing addiction. Today, approximately 20 people each day in Canada die from the effects of unregulated opioid poisoning, and another 8 or so die from the effects of unregulated stimulant poisoning. Often people are dying from polysubstance use also. They are combining substances, again, sometimes intentionally, more often because there is simply no way to know what is in the drug supply. Moving on, the term, I probably don't have to provide much of a definition to this audience, but I do think it's worth looking at how official definitions of disability present for some insight into how decision makers view it. So a frequently cited definition, according to the World Health Organization, says disability is an umbrella term covering impairments, activity limitations, and participation restrictions. An impairment is a problem in body function or structure. An activity limitation is a difficulty encountered by an individual in executing a task or action, while a participation restriction is a problem experienced by an individual in involvement in life situations. Now, quite overtly, this definition frames disability solely as an individual level phenomenon. There's no mention of how disabilities are defined, or in terms of the fact that disabilities are defined according to social and environmental kind of conditions, or influenced by social and environmental conditions. The Canadian government's definition of disability is somewhat more holistic. The paraphrased Federal Disability Reference Guide explains, disability is a complex phenomenon reflecting an interaction between features of a person's body and mind and features of the society in which they live. Disability can be the cause as well as the result of disease, illness, injury, or substance abuse. Reflecting this complexity are the different approaches to understanding the experiences of disability. According to the traditional biomedical approach, disability is viewed as a medical or health problem that prevents or reduces a person's ability to participate fully in society. In contrast, the social approach views disability as a natural part of society, where attitudes, stigma, and prejudices present barriers to people with disabilities and prevent or hinder their participation in mainstream society. So this definition, again, much more robust than what I kind of stated in terms of the World Health Organization definition, but it's still really intriguing to me for a few reasons. It acknowledges that disabilities don't occur in isolation. Mentions that although people are born with natural variations in ability, some of which are inherently difficult, societal responses to these differences instrumentally shape people's life's trajectories. So we can say that the Canadian government has generally adopted more of a social model of disability, at least definitionally. However, I'm more interested in how this definition plays out in practice. Another reason it's intriguing for the purposes of this presentation, of course, is the line, disability can be the cause as well as the result of disease, illness, injury, or substance abuse. Here we see the government implying that drug use, although it problematically uses the term abuse, can be the cause or an effect of a disability. Yet in another document, the Canadian Human Rights Act, disability is defined as any previous or existing mental or physical disability that includes disfigurement and previous or existing dependence on alcohol or a drug. In other words, the Canadian government is simultaneously claiming that drug abuse or dependence on either alcohol or a drug, which are not clearly defined terms, causes disability, is caused by disability, and is a disability unto itself, even if that person no longer uses drugs. And my focus on this may seem pedantic, it probably is, but it highlights a key tension when it comes to how drug use, and specifically illegal drug use, is categorized and treated. Legally and societally, we have not really decided if illegal drug use is a criminal issue or a medical issue. We haven't resolved if illegal drug use per se constitutes a disability, or if someone has to have a particular relationship with drugs, for instance, to receive a substance use disorder designation in order to qualify as disabled, and even if they do qualify, whether the appropriate response is treatment, punishment, or some combination thereof, if there's a meaningful distinction between the two, which I would say is arguable. Moreover, we haven't decided how we define use versus abuse versus dependence, what the objective of treatment or punishment should be, and if either of these is successful, for instance, by leading someone to total abstinence, whether they still qualify as disabled. Now, I'm not going to answer these questions for us in the next 20 minutes or so, but I raise them because I think they help illuminate why disability advocacy spaces and the disability justice movement more generally has had such a hard time including drug users. Drug use is not often considered a disability justice issue because it is behavioral versus innate, and more importantly, because despite the government's written definitions, drug use is still primarily treated as a criminal issue. And even those of us who are medicalized through substance use disorder diagnoses are not encouraged to see ourselves as disabled. Rather, dominant approaches to treatment instill in us that we have brain diseases, that, while biological, are progressive and permanent, and are somehow possible to pause through the pursuit of total abstinence, the success of which is predicated on individual willpower and hard work. So we really see this kind of category collapse and real definitional confusion around what drug use is and isn't. And given this lack of conceptual clarity surrounding not just drug use, but also substance use disorders and disability, it's not really possible to answer the question of what comes first, disability or drug use, at least on a population level. I can't make any definitive claims about whether disability causes drug use or drug use causes disabilities. All available data indicate that the two phenomena are interrelated or bidirectional and mutually reinforcing. What's more salient is, and kind of the overarching thesis of my presentation, is that irrespective of why someone starts using illegal drugs or the relationship with them, Canada's drug policy environment is disabling. Put different, someone who uses illegal drugs is going to be at an extraordinarily high risk of some form of disablement, not due to pre-existing disability and not due to drug use itself, but because Canada's drug laws and policies are designed to isolate, socially exclude, and impoverish people who use illegal drugs, particularly if they are isolated, socially excluded, and impoverished already. Now, to illuminate this point, I'm going to walk us through a few concrete examples of how drug prohibition is disabling. I'll begin with a brief example of how prohibition produces physical disability, but I'm going to focus more on how prohibition contributes to disabling someone politically, socially, and economically. And of course, I want to emphasize at the outset that prohibition's consequences are unevenly distributed. Everything I'm about to describe overwhelmingly applies to people who live at the intersections of poverty and disability, who are also more likely to be Black, Indigenous, and racialized. And I really do regret that I don't have time to speak to the targeted harms of prohibition for Black and Indigenous people specifically. Please understand that prohibition has always been about racialized social control, and I do strongly encourage you to look into the origins and contemporary manifestations of prohibition as a tool of colonial land theft, dispossession, and racial segregation. I'm happy to make recommendations for reading and listening during the live panel event on the day of the symposium, and hope to have the opportunity to elaborate on this further. Now, in terms of physical disability, in recent years across the country, we have seen an increase in drug-related brain injuries. Hypoxic brain injuries refer to injuries that occur when a brain is deprived of adequate oxygen, leading to cell damage or death, and in some cases, permanent disabilities for people. These injuries are occurring more frequently among people who use drugs because overdose events are becoming more complex and difficult to reverse. Whereas 10 years ago, the primary adulterant in the unregulated drug supply was fentanyl, so kind of the primary ingredient or substance that was added to the drug supply that people might not have known they were consuming was fentanyl. Now we commonly see a combination of adulterants that include carfentanil, which is roughly 100 times more potent than fentanyl, counterfeit benzodiazepines, nitazines, which are a class of drug that were deemed too potent to be approved for clinical use when they were originally created, and xylazine, which is used in veterinary medicine and has never been approved for use in humans. And unlike fentanyl, which is an opioid, these latter adulterants do not respond to overdose reversal medications like naloxone. So people are therefore taking much longer to be revived from overdoses, and some of them are enduring permanent brain injuries in the process. And these injuries are entirely preventable. We could avoid them if people knew the contents of the drugs they are consuming and were able to kind of dose themselves accordingly. That's just one example of how prohibition causes physical disablement. Now, transitioning to how prohibition is socially, politically, and economically disabling, I want to continue with the example of hypoxic brain injuries. Across the country, a narrative has emerged, and in some places I'd say has become pretty entrenched, that a certain class of drug users is too impaired to voluntarily pursue substance use treatment. Many elected officials, particularly in the provinces of BC, Alberta, Saskatchewan, Ontario, New Brunswick, I'm kind of just listing off the entire country. Many elected officials have implemented policies or are considering implementing policies to expand involuntary treatment for substance use. This is not a new issue, but it has ascended in prominence in political and public discourse. Often, associations are being made between drug use and brain injuries to claim that a drug user lacks the capacity for rational decision making, and involuntary treatment is being presented as the only kind of humane solution for people who are too sick to know what's best for them. Now, what this narrative omits is that brain injuries can be difficult to diagnose. The symptoms of brain injuries often resemble the symptoms of trauma, which also intersects with poverty, disability, and illegal drug use. Brain injuries can also be exacerbated by trauma, and having a brain injury does not preclude someone from being able to make decisions about their own health care and lives. Moreover, the political popularity of involuntary treatment is largely being driven by a perceived uptick in public drug use among people who are visibly poor and homeless. Rather than acknowledge that poverty and homelessness are increasing across the country and addressing them directly through poverty reduction programs and investments in things like affordable housing solutions, many of our elected officials are eager to perpetuate the myth that restoring public order merely requires disappearing poor drug users by incarcerating them in medical settings. This reticence to admit that we are in a historical moment where capitalism's fault lines are being laid bare and leading to more material precarity for almost everyone is one of Prohibition's foundational kind of ideological purposes. It functions really beautifully as an ideological shield because it diverts our attention away from structural and systemic level issues and towards individual ones. Now, I want to offer more example of how prohibitionist logics disable people. The label of drug user or someone with a substance use disorder, particularly someone who has a substance use disorder and has a brain injury, is what Miranda Fricker refers to as a tracker prejudice. Fricker defines tracker prejudice as a prejudice that consistently and systematically undermines a person's credibility due to their identity, that will follow or track them through every domain of social activity with compounding deleterious consequences. So speaking about this hypothetical person who uses drugs who may have been diagnosed with a brain injury, let's say that they are involuntarily institutionalized for a period of time. Automatically, a few things could happen. If they are employed, they could lose their source of income generation. Finding new work will be difficult, especially if they are kind of institutionalized for a fairly long period, and especially if they are one of millions of people whose employers have workplace health and safety policies that prohibit impairment in the workplace. Now, on its face, preventing impairment in the workplace sounds reasonable and quite important. However, as someone who has worked with a variety of unions in recent years, I can report that many employers, if not most, automatically link any illegal drug use with impairment, even if it happens outside of working hours. Specifically, many unions have written policies that prevent someone who has disclosed illegal drug use or has been diagnosed with a substance use disorder from returning to work until they have been assessed by what are called independent medical examiners, or IMEs. IMEs are doctors who have frankly often designated themselves as addiction experts. That specialization's a bit murky and there aren't a lot of pathways for getting it in Canada. So IMEs are at times self-professed addictions experts, many of whom have formal relationships with employers, and they're tasked with determining whether an employee who is sent to them is fit to return to work. However, many IMEs also often own, operate, or sit on the boards of abstinence-based substance use treatment centers or companies that provide urinalysis drug screenings, P-tests. Almost to a person, any employee who is sent to an IME will be diagnosed with a substance use disorder, and they will be mandated to pursue abstinence, as well as forced to pay out of pocket for regular urinalysis screenings as a condition of returning to work. Now, this problem is pervasive. To cite one high-profile example, In 2013, Byron Wood, a registered nurse who worked on Vancouver's downtown east side, was diagnosed with a substance use disorder by an M&E and mandated to attend Alcoholics Anonymous, an abstinence-based addiction treatment fellowship, as a return-to-work condition. As an atheist, Byron objected to AA's religious undertones and asked to attend an alternative secular program instead. He also asked to be permitted to use a medication that reduces cravings for substances and to be referred to a new doctor. All of these requests were declined. His professional college and employer, Vancouver Coastal Health, stated that they only worked with IMEs who follow the 12-step model. Byron was ultimately fired and lost his professional license after failing to attend enough 12-step meetings. Fast forward to 2019, and Byron settled a complaint with the health authority after filing a lawsuit with the BC Human Rights Tribunal, alleging he was discriminated against as an atheist when he was fired for quitting AA. He's gone on to found the Workers for Ethical Substance Use Policy, or WESUP. I recommend looking into them if this resonates with you at all. And the health authority has since changed its policy to permit employees to have slightly more choice in their treatment options. But Byron's case is one of countless like it. We only know about it because of his successful lawsuit, but every day people who are designated as disabled by virtue of their substance use are subjected to human rights violations that preclude them from participating in the economic sphere. With any other disability, it would be unthinkable to require an employee to attend a religious program to be healed as a condition of their employment. Yet we broadly accept this as a reasonable approach for people who use drugs, because prohibition has so perverted our collective sense of what is normal and appropriate. Now, I want to touch on housing, also very important, and how the label of drug user or person with a substance use disorder will track someone through their housing journeys if they live at the intersections of disability and poverty. The same hypothetical person who has been involuntarily institutionalized for substance use because they are poor and their drug use is visible is even more likely to contend with housing precarity after they get discharged. They may have missed rental payments due to being institutionalized and lost what housing they did have. They may also have been severed very abruptly from their social networks and are now less likely to have access to informal supports and community care. Those of us who are disabled recognize how important that can be outside the traditional medical system. And more obviously and detrimentally, they may be forced to navigate the shelter system having been labeled as a drug user and or a drug user with a brain injury. Now, very few shelters in Canada permit drug use among clients. Only a few have safe consumption sites on site, and only slightly more than that have harm reduction programs or will kind of allow any harm reduction equipment on site. And here I'm referring to things like sterile syringes for injecting. The majority of shelters in Canada are still abstinence-based, and many will discharge someone who is caught using drugs on the premise. Now, arriving with a substance use disorder designation, or being known as a drug user, is going to make a person that much more vulnerable to surveillance and expulsion. And because many shelter staff or frontline staff communicate with each other, getting expelled from one shelter often means being less likely to access another. And of course, we know that being unhoused makes attaining and maintaining stable employment nearly impossible, which in turn makes attaining and maintaining stable housing nearly impossible ad infinitum. And this is how we see many people who use substances become street entrenched. They, or I'll say we, I have experience with this, get ensnared in cycles of unemployment, poverty, and homelessness, often with our entry point to the cycle being negative or outright abusive treatment from the medical system. And I won't get into too much how just kind of traumatic and destabilizing kind of mentally and emotionally all of this is, but suffice it to say each of these entry points, whether it be involuntary institutionalization, poor treatment at a shelter, the inability to access employment as we become further street entrenched, is devastating and disabling unto itself. And once a person is, so-called street entrenched and codified as an illegal drug user, they will also have a much harder time accessing income and disability supports, family reunification programs if their children have been apprehended by the state, cultural supports, and even supports for gender-based violence. They are also much more likely to be exposed to criminal penalties for drug use. And that brings me to a few pieces of legislation I want to kind of briefly discuss to hammer this point home. I'm going to briefly just cover two recent pieces of legislation that were expressly designed to disable already disabled poor drug users. The first, Bill 34, or the Restricting Public Consumption of Illegal Substances Act, was initially passed in British Columbia in November of 2023. The act would have made it illegal to consume substances within 15 meters of a playground, school, or skate park, in any place that the public has a right to access, including sports fields, beaches, parks, outdoor areas established for the purposes of recreation, and any place that was within 6 meters of an entrance to a place the public has access, a workplace or a prescribed place. So it sounds like I've just covered a lot of places, and yes, in other words, put bluntly, Bill 34 would have made it illegal to consume drugs in any outdoor space other than an alleyway, with a few minor exceptions. Now, a reminder, I said at the beginning that the CDSA does criminalize drug possession, but not drug consumption. Again, of course, in order to consume drugs, someone must be in possession of them. Yet the government's rhetoric around Bill 34 was quite disingenuous because it implied that it didn't already have the power to criminalize drug use in public places, when under federal law, use is automatically, or kind of, I should say, de facto criminalized by virtue of being in possession. Even more concerning, Bill 34 would have afforded police sweeping powers to stop, search, and seize possessions from anyone they suspected of recently using drugs in public space. The wording of the legislation was vague, with the term reasonable suspicion of drug use left entirely up to police discretion. Police could also instruct someone they suspected of recently using drugs to leave public space under threat of fine, arrest, and incarceration. So put differently, Bill 34 would have been effectively a blanket pass for police to profile poor, racialized, and disabled people. And for these reasons, the BC Supreme Court Justice issued a temporary injunction in late December 2023 that prevented the bill from coming into force. In his ruling, the Chief Justice agreed that in the context of a severe public health emergency, the bill would cause irreparable harm to people who use drugs and to the frontline workers who respond to overdoses if it came into force. Since then, the bill has been repealed by the province. Although this was a modest victory, we now see a very similar piece of legislation in Ontario's Bill 6, or the Safer Municipalities Act. As with Bill 34, Bill 6 allows police to direct individuals in public spaces, including those in encampments, to stop using illegal substances or to leave the area. If an individual does not comply, police can issue them a fine or arrest them. And this bill also enhances penalties for people who deliberately and continually trespass in public space. Also, as with Bill 6, the wording of the legislation is vague and affords regional policing forces more power than they are currently afforded under the Federal Controlled Drugs and Substances Act. And I include these two examples to underscore that prohibition is disabling, particularly for people who are poor. Wealthier people use drugs in their private residences constantly, but they are broadly insulated from the outcomes I've just described. So once more, prohibition does not exist to keep communities healthy and safe. It was designed to isolate, socially exclude, and impoverish those who are already isolated, socially excluded, and impoverished. In other words, those who the Canadian state has deemed disposable. And I strongly believe it is our job as disabled people and collectives who are concerned with disability justice to denaturalize or disrupt the taken for granted assumption that drug-related disablement is natural and inevitable. And that brings me to my next session, which is policy solutions to the problem. The first and really only policy solution to drug policy-related disablement is to end drug prohibition. This means legalizing and regulating all currently illegal drugs. And now often when I say this, I am met with strong reactions. And I want to clarify that when I say legal regulation, I'm not advocating necessarily for models of regulation that resemble those we currently have for alcohol and drugs like cannabis. In the drug policy world, we have a spectrum of drug policy options that run from an unregulated market, so the criminal market under prohibition on one extreme end of the spectrum, to a legal commercialized free market on the other extreme end. And this is kind of where alcohol and cannabis currently sit. And on both ends of this spectrum, the primary motivation is profit. Neither the unregulated market nor the commercial market is particularly concerned with public health or safety. Certainly neither is concerned with things like equality, equitable resource redistribution, or human rights. Both generate revenue for monopolies. Organized criminal groups as a monopoly in the unregulated market, and corporations in the commercial market. And so the policy option that my colleagues and I advocate for sits kind of in the middle of this regulatory spectrum. There's a bit of a sweet spot here, where drugs would be legally available and therefore subjected to strict regulatory controls that dictate precisely what their contents are, who can manufacture and distribute them, and who can access them and where. But in this ideal model, there would be kind of protections embedded that prohibit things like corporate profit making, prohibit advertising, and although I'm getting a bit utopian here, at least in this exact political moment, the ideal model would also be global in nature, meaning that we would import the raw materials to produce drugs from regions of the world that have been most harmed by prohibition, such as throughout Latin America, where Western-backed intervention under the guise of the drug war has disabled entire communities and nation states. Once more, I would love to expand on that and would be happy to at a later date. And again, I'm not claiming that legal regulation would eliminate all drug-related risk. I'm not naive. Consuming drugs can be dangerous, and some people form relationships with drugs that warrant supportive voluntary interventions, me included. However, to reiterate, under prohibition, drug use is far more dangerous than it has to be. And returning to the purpose of this presentation, the logics of prohibition have become embedded into all of our societal systems, institutions, organizations, and interpersonal interactions with disastrous results. Now, because legal regulation may not be viable in this precise moment, shorter-term policy imperatives include fully decriminalizing drug possession and offering people who use drugs pharmaceutical-grade alternatives to the unregulated drug supply. That could occur through a prescription model, could also occur through more of a compassion club model. Both of these policies have been experimented with in very modest and I will say half-hearted ways. They've never really been implemented at scale, or even to the extent that a significant proportion of illegal drug users have had the chance to benefit from them. If they were, rates of overdose fatalities and physical disablement would decline. What's more, the stigma and discrimination that flows from prohibition would at least be somewhat less embedded into people's daily lives, meaning that the likelihood of political, social, and economic disablement would also be reduced. And I'm just looking at time and recognizing that I have virtually run out of it. So I was going to expand on, a few calls to action in terms of incorporating the perspectives of drug users into disability advocacy and activism. But I will have to kind of leave it there. I hope we can all use our imaginations. Disability justice is a broad concept and it manifests differently, sometimes in some very hyper-local and informal ways. But returning to kind of the overarching purpose of this presentation and this symposium, I do really want to highlight that there is an urgent need for solidarity. And there are many folks who for various reasons can't or won't kind of fit that model of folks who are stereotyped as the deserving poor or the worthy poor or the poor who do everything right in the eyes of normative society and therefore deserve access to resources and material comforts. All of us do, and it really shouldn't matter that some of us need to engage in what is a criminalized activity to survive living in disability poverty. So thank you so much for tuning in, and I hope to be able to chat further about this. All right, thanks.